Dr. Patti Robinson has explored integrated care from the perspective of clinician, researcher, trainer, and healthcare consultant for the past 20 years. Current activities include providing consultation services to healthcare systems that are, number one, integrating behavioral health care services into primary care, and two, seeking to improve treatment of chronic pain, chronic disease, and care to children, women, and or the elderly. And finally, systems that are attempting to increase the use of brief, evidence-based cognitive behavioral therapies in primary care and other settings. Dr. Robinson is the author of numerous articles and book chapters, as well as 5 books, including Behavioral Consultation and Primary Care, A Guide to Integrating Services. We're so pleased to have her with us today. Before we get started with the webinar, I just wanted to go through a few housekeeping issues. The first of these, we have lots of folks on the call today, but we'd like to try to entertain questions from you as Dr. Robinson is going through her presentation. You can submit those questions in one of 2 ways. There is an opportunity for you to write the questions in, and then I'll translate those to Dr. Robinson. Or the other opportunity is you can raise your hand. There's a tiny little green hand or yellow hand next to your name. If you raise your hand at some point during the webinar, I will administratively unmute you and you can verbally ask that question. I believe Dr. Robinson is going to be leaving some time toward the end of the webinar today for interaction and questions and answers. So we'll get to that point then. Also, yeah, I believe everybody will be administratively muted at this point. And we'll go ahead and get started. So Dr. Robinson, I'm going to pass the screen to you and we'll go from there.
Thanks, Polly. It's a pleasure to be a part of this, and let me see, show my screen. You passed it to me and then it went away. It'll probably come back.
I think we are seeing your screen right now, so if you can pull up your slide deck.
Oh, okay. I'll just pull up my slide deck. I can do that. All righty. Starting with...
Dr. Robinson, we are still not seeing your slide deck. We're just seeing the GoToWebinar screen.
That's... it says show my screen. I was just going to my PowerPoint on my computer.
Sure.
Should I do that?
Yes. Yes.
Okay. All right. Well, let me try that. Is that working?
Let's see. Yes. Yes.
Oh, okay.
Yeah.
And so I'll just say play from current slide.
Perfect. Yes. Okay. Perfect. Right. Thank you so much.
So, you bet. Okay. So, yeah, I think the problem is, let's see if I do it. No. Okay. I'm going to go at it this way. Does the slide look good that way? Oh, okay. Now I'm good. All right. Here we go. Yes, having strong clinical skills for intervening briefly is probably the foundation for feeling successful and staying in the field of primary care behavioral health, whether you're a primary care provider or a behavioral health provider. So I look forward to sharing a tool with you today, and hopefully all of you received that as well as some other materials in your email from Polly on Monday. if you haven't had a chance, you might want to flip over and kind of quickly print those materials out today because they'll also be a reference. Did you already talk about the SIG history? Probably we're all good to go there.
I really didn't. No, I didn't talk about the SIG history. So if you'd like to, that would be terrific.
Mm-hmm. Okay, well, it's brand new. Chris Hunter and Jeff Ryder helped get this organized and launched just earlier this year. And Jennifer Funderburg and others are trying to put together a series of webinars. This is the second one. Travis Cost, I think, presented on the primary care behavioral health model a month ago, and Jeff Ryder will be presenting in December. So keep looking at the listserv and you'll receive information about those webinars and have a chance to interact with others about questions and issues pertinent to the primary care behavioral health model. All right, let's see, my financial relationships. I receive royalties for books that I write for Springer and New Harbinger. And our learning objectives today include my talking about specific core competencies, hopefully in such a way that you understand them and can evaluate yourself. What are your strengths and weaknesses? And I want to help you articulate questions you might have about how to adapt evidence for clinical interventions to the primary care context, because it's a different context and requires adaptation. Might talk a little bit about group services and then talk about the importance of assessing outcomes in our primary care behavioral health services. So I will just talk briefly about the PCBH model just because some participants today, this may be your first experience with the primary care behavioral health SIG of Collaborative Family Health Association. So I'll just describe the model briefly. Then we'll talk about the ByCat, which is the Brief Intervention Competency Assessment Tool. That's the instrument that Polly mailed out on Monday. And then we'll go through some slides where I can kind of talk about average and exemplary competency levels in the specific brief intervention areas on the ByCat. And at the end of our webinar today, I'm going to encourage you to develop a career development plan to improve your competency in one or more areas and to kind of plan for some support from one of your peers in that area. So in terms of the primary care behavioral health model, we talk about the primary care provider as the person that's retaining ultimate responsibility for patient care, and the behavioral health consultant as the member of the primary care team that has expertise in addressing all behaviorally influenced issues in primary care. These, of course, are mostly in regards to the patient population, but also assisting the team with team development and system issues that may come up in implementing the patient-centered medical home. So the primary care behavioral health model brings this mental health professional into primary care, and the behavioral health consultant really provides two services, the first one being brief interventions and the other being pathway services. I'm going to explain both of those today as we talk about the different competencies for working briefly and effectively. Brief interventions typically are the one-on-one or one BHC to a family or a couple. They may involve screening, they always involve assessment, and they always involve behavior change planning. They often occur on the same day as the medical visit. The behavioral health consultant also provides groups. Groups in primary care are different from groups in specialty mental health. The emphasis and design of these groups is based on access for patients. So if we provide a series of classes, we design them so that patients can access any group at any time, and they are not sequentially arranged in a hierarchical fashion that assumes ongoing attendance, although that can happen and is welcome. The group kinds of services may be classes, workshops, and it may be group medical visits. Groups are a great way for the behavioral health consultant to intensify skill training opportunities for patients. Step up, step down just refers to the service that the behavioral health consultant offers in terms of assisting patients with changes in levels of care as need be. These are some resources on the primary care behavioral health model. I worked with the state of Oregon over a 2-year period. We put together a implementation toolkit, and that's available on the web, so help yourself to these materials. I also want to say that Jeff Ryder and I've just finished a 2nd edition of Behavioral Consultation and Primary Care Guide to Integrating Services, and Springer is really on this, and it's going to come out soon, maybe winter, maybe December or January. Prior to the book release, Jeff and I plan to launch a website for the book, so that would be behavioralconsultationandprimarycare.com. Probably within a month, 3 weeks, I will have the website up. It'll have a lot of free downloads of materials to assist in primary care behavioral health practice, as well as some videos. So why be brief? What are the benefits of brief visits? Anybody want to type something in? Here's a chance to interact. This always takes a while, so Polly might summarize some of the things that you're saying, but I'll go ahead and kind of give you some answers because you probably are going to have more questions about other things momentarily. Polly, did you have something to say?
Sure. For those who are just briefly emailing me that you didn't receive the ByCat, I'm trying to send those out as we go. And it looks as if I see a couple of comments, problem-specific, consistent with primary care model, and it meets the PTs where they are with limited time and resources.
Absolutely. Those are great reasons for being brief. It's what our patients prefer. And it's respectful of resource requirements. We have a lot of patients. We don't have enough providers. We often don't have enough exam rooms, and reimbursement's limited. Patients, they prefer what? They want help when they want help. So service at the time of request, that requires that we be brief and to focus on the problem of concern to the patient. That really helps us maximize engagement in behavior change. Interventions fit with the patient. Brief interventions fit with the worldview of most patients. They really, while psychotherapy is like awesome and great for people like us, many of us psychotherapists who view the world that way, but a lot of times patients just want to fix it. So we can, when we intervene briefly, we can quickly assess patient strengths and weaknesses and base our brief interventions on those and provide clear action steps for the patients. So now I want to introduce the ByCat. How do you like that? Is that sexy or what, ByCat? So ByCat stands for Primary Care Behavioral Health Brief Intervention Competency Assessment Tool, ByCat. So on this tool, you'll see, and we have the slide up, so those of you who don't have it right now, I'm gonna have on slides all of the items. They're abbreviated briefly, but what you might do is just use a blank piece of paper, and you can assess yourself as we go through the slides, even if you don't have this printed out, so no worries. What you're going to do is you're going to rate yourself on a scale of 0 to 10. 0 is not adequately competent in the area, and 10 is exemplary. So 5 is kind of in that adequate range. And in terms of behavioral anchors, we think in terms of low being in the range of 0 to 3, adequate being in the range of 4 to 6, and exceptional in the range of 7 to 10. I believe Polly also sent out a book chapter that I wrote with a colleague introducing the ByCat. So after the webinar, you can read that. It's on a recently published, in a book chapter in a recently published book, Mindfulness and Acceptance for Social Workers. In addition to describing the ByCat, there's an example of a professional new to primary care behavioral health who applies this tool to developing a career plan and works to become, systematically works to become more competent and more successful in this new skill set. So basically, this tool has 4 areas. First is context, primary care context. Second is intervention design. Third is intervention delivery. And fourth is outcome-based practice. So let's start with the first area. By the way, there are 20 items, so you're going to have 20 ratings. So probably fits easily on one sheet of paper. So domain 1, item 1, is understanding the most common problems of clients in your setting. How able are you to do this at this point? This is getting at that population-based care perspective we take in the primary care behavioral health model. Do you understand the most common problems, and are you promoting access? So this really involves shaping services for high-impact populations and coming up with marketing that works in terms of engaging patients in your clinic. An example of marketing is a new area for most of us as behavioral health providers. But an example might be having brochures about your services in the exam rooms, having exam room posters describing your services, having workshops that address the needs of high-impact populations, and placing those even in places in the community that announce the services at your clinic. Second is addressing barriers to client access of your service. So working to minimize stigma. Of course, just being in primary care, you're doing a lot to minimize stigma. But you want to make sure you're in the right place in primary care, so you don't want to be down the hall away from the primary care action. Your service you want to seem very routine for people. And then are your hours of PCBH service consistent with the clinic hours of operation? And what can you do to better address this? An example, many times when there's more than one behavioral health consultant in a clinic, they will stagger their hours over the lunch hour so that lunch is always covered. Third, how are you doing with working to share your skills with other members of your team? Remember, the primary customer in the primary care behavioral health model is the primary care provider, the nurses, the members of your team. So how are you doing in terms of sharing your skills? Are you charting in a way that helps them support your behavior change plans? When you give feedback same day or in your chart notes, are your descriptions transparent, easy to understand? The fourth and last area in this first domain is defining the demands of your practice setting and making adjustments as necessary to your practice. So that let me give you kind of like exemplary in that area would like be able to kind of handle the action when you have maybe 4 or 5 referrals in a 2-hour period, because you're able to kind of adjust your clinical interventions so that you can see all the patients when they're there and at the time of need. This really requires a lot of on-the-spot kind of thinking and problem solving and interacting with patients, negotiating time in a way it's really very model specific and new for most of us. Jeff and I include a chapter in the new edition of Behavioral Consultation and Primary Care called A Day in the Life of a Behavioral Health Consultant, where we really try to teach this skill of kind of working with schedule requirements, because it's often kind of feast or famine in primary care for the behavioral health consultant. Well, let's move to the second domain, which is intervention design.
Patti, before you move to the second domain, we do have a question. Christine Borst asked about the use of the word client instead of patient, since it is in a primary care setting where patient is the customary term. Do you have any comments about that?
I prefer patient, and I think that's just one more way that we can connect with our team members, and is to use the same language. So I tend to use appointment or visit rather than session, and patient rather than client. If there is client in, there's client in the ByCat, and I might explain the reason for that. This is a tool that really is intended for behavioral health providers that work in any brief setting. Primary care is a brief setting, but there are other brief settings, and sometimes patients call their patients clients there. So you can change it to patient on your ByCat. You have a Word document. Good point. So second domain, intervention design. First, introduce yourself in a way that promotes change, because we're trying to promote change briefly. So talking about what your job is and what's going to happen in the visit is really important. So saying that your job is to help them improve their health and that you're going to come up with one or more strategies to help them today is important. Also very important is to say that our patients may improve without further treatment. The modal number of times patients see behavioral health providers in primary care is 1. So we want to take advantage of that and maximize the opportunities for patients to change. So seeing a lot of people do benefit from a single visit, it's important to include systematically in your introduction. Second, in this area is targeting a problem of concern to the patient at the time of the visit. We're going to talk at the end of the webinar today about functional analysis, and so we'll talk more about targeting, finding a target problem, but you always want to start with kind of what's on top for the patient and prioritize that. I'll also recommend some questions that you can use to quickly identify client strengths, in your intervention design. And fourth in this area is to normalize the client's problem and avoid pathologizing explanations of the problem. An example of this might be for a patient referred for depression. Oh, so the doctor says you've been having some difficulties with symptoms of depression. What tends to bother you the most right now? And then to kind of look at how it's impacting functioning and the triggers, and to make it kind of understandable that the patient is experiencing fatigue since taking a second job or something like that because of financial problems. Using evidence-based interventions is really important too. This is one of the items, important here is to kind of go for the behavioral when you have a choice, because they fit better in primary care, and to focus on function rather than symptoms, because functioning, turns out, that's what people really care about. It's the ability to be a good mother and to sit down and listen to the kids more so than just not feeling sad. Also think it's very important that we include values discussion when we talk about behavior change, because it creates a context for resilience in behavior change, and to provide patient with written information about the plan. Great resources for evidence-based interventions and adapting them to primary care. I really like Hunter Goody-Ort and Dobmeier's book, and they're submitting a second edition in January, so that will probably be out later, 2015, so look for that. Family Systems in Health has a lot of peer-reviewed articles relevant to behavioral health consultants. I like also the Journal of Health Psychology and the Journal of Cognitive and Behavioral Health Practice, the Journal of American Pediatrics, and the STFM, Society for Teachers of Family Medicine. They have a journal too. So primary care journals are also very useful in terms of looking at the evidence for behavioral health consultant interventions. Just a few more in this important area is focusing on small changes, one step at a time, and framing interventions as an experiment to see what happens. That really gives the patient permission to fail. Are you doing that? And maybe you do that sometimes, but competence is about being consistent. So kind of assess yourself in terms of that quality of being consistent. Identifying and addressing barriers to patients' follow-through with behavior change plans. So do you consistently really go into detail about what happened when they tried to implement a plan when they returned for follow-up? Assessing confidence in behavior change plans at all visits is really important, because patients don't do things they're not confident in. So the way I recommend that you ask about this is on a scale of 1 to 10, how confident are you? 10 is very confident. If you get something below a 7, you want to renegotiate that plan, come up with a different plan that the patient feels more confident about. And then at follow-up, when the patient does report improvement, help them take ownership of behavior change. We don't want to say something, well, finally, you're improving, you're doing what I told you to. Not that, but instead, wow, so you got yourself to do this, how did you do that, blah, blah, blah. So the third area is intervention delivery. We are confronted with huge needs for our services when we enter into primary care. So establishing care pathways help us increase efficiency and reach in our effort to bring evidence-based care to patients. And so a pathway, a primary care behavioral pathway always targets a specific group that we want to improve outcomes to. And it also specifies what the behavioral health consultant will do in the way of assessment and interventions. Finally, a pathway also indicates the ways, kind of the goals of the pathway in terms of what it's trying to improve and the assessment strategies. How are you going to assess the pathway's success given its goals or objectives? Pathways may include groups, but they need not. An example of a pathway might be having all newly diagnosed diabetics referred, or new patients newly diagnosed with diabetes referred to the behavioral health consultant on a same-day basis. The reason, the goal for this would be to improve self-management skills by using the behavioral health consultant to assess motivation, readiness, and to assist with the emotional acceptance of a diagnosis of a chronic condition. Next, in terms of intervention delivery, what are your skills in terms of offering groups to clients? So I would think in a full-time behavioral health consultant practice, you'd have 3 or 4 groups a week. So maybe 10%, 15% of your time would be in group visits, perhaps more as your practice matures. And the fourth domain is using outcomes to assess your practice. So first, how are you doing with using outcomes that are tailored to assess brief interventions? An example of this would be like asking problem severity ratings. So you can quickly say a person is referred for their child is having behavior problems. So you might say on a scale of 1 to 10, how big of a problem are your son's behaviors at this point in time? 1 to 10, 10 is a very big problem. You can ask this question at follow-up visits as well. It's very time effective and gives you an idea, actually, of patient distress, which is an indicator of whether or not the patient is going to possibly come back or not, because we do know from a variety of studies that as distress drops, patients are less likely to return to see us. So we want to use it when it's there and know how we're doing. Second is, I mentioned this to some extent, but demonstrating a willingness and ability to change your intervention based on assessment results. So an example of this is changing in response to a confidence rating that's lower. Another would be when the patient returns, if the plan from the initial visit hasn't worked, then being ready and able to engage in further assessment or functional analysis to develop a better plan or more workable plan for the patient. The third is using outcomes in aggregate to evaluate the effectiveness of your practice. So if you routinely complete mental health or health-related quality of life measure at initial and follow-up visits, you can use this clinically, but you can also use it through your electronic health record to obtain aggregate data and to better evaluate your practice. So that would be exemplary in that area. So what I'd like you to do, I'm just going to skip to this one for a minute, is to look at your ByCat and look at your scores in each of the 4 areas. And think for a moment about maybe 3 targets, 3 specific things that you would like to move from low to adequate. Again, low 0 to 3, adequate 4 to 6, or above is exemplary. Or you want to move from adequate to exemplary. And as you think about these 3 areas, who do you know that is a little better than you in these areas? If you're a primary care provider, a nurse, there may be another primary care provider that you think is probably better in some area, or it might be that the behavioral health consultant would be better in that area. It might be someone that trained you in graduate school. Who cares about your career? And who do you trust to ask for support? And then when are you going to check in?
Patti, we do have another question.
Sure.
Travis Koss asks, how do you get protected time to review the sheer amount of data you have for initial and follow-up measures?
Well, I think you want to enlist your planning department or others so that you're not the only one doing the data review. So I would say make it a project for your quality improvement committee or your planning department. Move it to a management kind of activity. Seems everybody has dashboards about how they're doing, and the primary care providers are not evaluating their own metrics for their practice. They're just looking at the data provided by others. So I'm hoping that everybody is coming up with a plan. That's one of the goals for today, in terms of furthering your skills for working effectively and briefly. But I wanted to kind of talk about also kind of the core areas in the initial visit, because this is really where you start to put these competencies into place and in the most clinical of interactions. So you do your introduction, and then the life context questions are just questions that help you quickly engage patients in a relationship. This is kind of a broad assessment where you're looking at the patient's resources in terms of relationships, family, friends, hobbies, and resources, financial, work, and play, what they do for fun, how they connect with their community, and just kind of their health burden or health factors, health risk factors, disease. All of these questions, I'll be glad to send a list of them. I have one for adolescents, one for adults. In fact, maybe I gave that to Polly, but they can be asked in 5 minutes. So you can start with your introduction and do an aggregate assessment in 5 minutes, life context 5 minutes, and then you move into kind of the heart of the intervention, the brief intervention, which is all about functional analysis. And that really involves 3 steps. The first is problem specification. Sometimes that's very directly related to the referral, for example, with sleep. But as you kind of specify the problem, it may change. Example might be someone referred for headaches, and you start to kind of ask questions about the problem, and you find out that really the headaches occur after marital arguments, which are 3 to 4 times per week. So you adjust your conceptualization, and conceptualization means just having one or more hypotheses about the function of the behavior based upon the results of your analysis in the problem specification. So it's a very behavioral kind of approach that leads to the identification of a need for a new skill, a new behavior, new information, and then you spend your time kind of helping the person learn that and implement that in their lives. At follow-up, again, outcome measure, assessing improvement. So is the problem getting better, worse, or staying the same? Getting into detail about that. And then how did it go when you implemented the plan? What parts did you implement? Did they affect the problem? Were there other things that you did? And maybe the plan is working, and this will be a short visit. The follow-up may be only 15 minutes in that case, because you can move it back to the team for ongoing support, of course leaving the door open for the patient to return as need be. Now, if needed in the follow-up visit, you may want to do more functional analysis, for example, if the patient is not improving or has improved just a little bit, you may want to revisit problem specification, conceptualization, and development of a stronger plan. Also the case, for example, if you help a person with a relationship problem and they return and they have a new problem. For example, they want to stop using tobacco products. So.
Patti, I did just forward to the full group a resource submitted by Robin Lynn Treptow, and she, the resource is, she was referred to the CHADIS assessment system by a colleague, and she has on that the website that they can go to learn more about that system. They can calculate a wide variety of metrics applicable to PCBH settings. So that should have gone out in the chat, the resource for that, to all of the people on the call.
Thanks, Polly. So I think we have time for a few questions. We've just got maybe 5 minutes I want to do at the end in terms of a wrap-up. So these are some ideas for questions. Do you have questions about functional analysis? Do you have questions about how to share your conceptualization with the patient? What clinical problems are challenging to you? And do you have problems completing visits in less than 30 minutes? Most of my work as a healthcare consultant trainer is training behavioral health consultants on the job training, so core competency training. So I actually shadowed them in their practice, and I use a primary care behavioral health core competency tool and evaluate them. So it's modeling, guided rehearsal. And I think, you know, people can get a lot of information from webinars. They get a lot of helpful information from reading and going to workshops. But when they go out to their clinics and they're practicing, it's very common that they have trouble with practice management, struggling with completing visits, specifically in less than 30 minutes, and that would include allowing time for feedback in that 30 minutes to the team, and also charting. So, questions?
Yes, and as a reminder, if you do have questions, feel free to either type them in the little question organizer, or if you'd like to raise your hand, I can unmute you, and if you're on the phone or your computer has a microphone, we can just field that verbally. So are there any questions, comments? Patti, our first question is from Teresa Jacobson. In a primary care setting, the BHC does not do a traditional diagnostic assessment, correct?
Yes, Teresa, you're correct about that. We simply don't have the time. So in this model, what we're doing is we're taking the target problem. So we have a referral problem that's been kind of agreed upon by the patient and the PCP, and then we use the tools of functional analysis instead of our diagnostic questions coming from DSM, where we're trying to kind of come up with a diagnosis and then match that to often a manualized treatment. Developing an overall treatment plan. We don't do that. Instead, we do functional analysis. The goal of the visit is to come up with a behavior change that helps the patient function better in their life. You know, be able to work, have meaningful leisure activities, most people, they really value relationships with their family, with other people. They feel connected to the community. In other words, we're trying to help them kind of live a more meaningful life, a life they choose, they would choose if they could choose it. Very different than a diagnostic evaluation.
Very good. Any other questions? Okay, it looks like we have another one from Francis Belcher. The question is, I would be interested to hear a brief discussion on the necessity of referrals to off-site specialty mental health providers and how that can maximize the client experience of behavioral health practice.
Okay, well, I think the answer is it depends. You know, certainly there are always going to be patients that we see in primary care that are going to need more specialized care, at least briefly. And so I think the job of the BHC is to try to help them access that and then welcome them back after the episode of specialty care is completed, welcome them back and translate the gains they've made so that the team is able to support them over time, so kind of to develop that relapse prevention kind of plan. Now, another group of patients would just be patients that prefer psychotherapy and have the resources to pay for it or to, you know, access it through a healthcare plan. And certainly the BHC can help them access that or find out about resources. I think we'll always have a small group of people that would benefit from that or want that. And certainly the BHC doesn't want to get in the way of that, but to facilitate that. I would say most of the time, though, it's very challenging for the BHC when we see patients that we are thinking like, oh, they may need something more, they may need a lot more than what I can do, because we don't have studies that say we can make that determination. It's very hard to determine which people are going to need more intensive care with a great deal of accuracy. So I really encourage BHCs to always start by trying to help. And you can mention specialty resources, of course, if you think those are indicated, but try to help. Use the tools of functional analysis. Try to come up with a plan that helps the person function better, and always, of course, check them back if you're thinking they need a higher level of care. And what I find many times is that if people implement the plan, they're better. They get better, and they prefer to just stick with their primary care team. Available studies suggest that about 90% of primary care patient needs in terms of behavioral health issues, about 90% can be met at the level of primary care.
Thank you, Patti. And let's field one more question, and then we'll give you some time to wrap up. Our last question is, how do you share your conceptualization in a non-pathologic, I'm not going to be able to say this word, pathologizing and hope-inspiring and brief manner? This is from Nicola DePaul.
Okay, that's great. You know, I think that conceptualization is so critical. I start with a summary, and so the summary is like where you're describing the results of your target problem export or your problem specification. So you're saying, I'll give an example. You start with a summary, so it might be, so you started having trouble with sleep when your new baby was going through the colicky period about 6 months ago, and now the baby is sleeping better, but you are not. And you are tired during the day, and you feel bad about being tired as a new mother, and you feel you should be happy. And then you're drinking coffee late in the day to try to keep yourself awake and functioning. Is that right? So that's step one, kind of the summary. And then if you've got that right, and they agree with that, and you said it in a non-stigmatizing way, you're creating openness for behavior change. And then you can say, so does it make sense to you that you need some new skills for putting yourself to sleep at this point in your life? And then I always like to say, so there's a couple of directions if I have more than one hypothesis. So I might say we could really look at relaxation, or we could look at ways to relaxation maybe in mindfulness of wakefulness during the night, or we could look at just sleep hygiene issues as they occur throughout the day. Changing up some of those behaviors, which makes sense to you. There might be, I can do both, but people like to have a choice. So that's how I go about it. It's a critical part. We really don't have time to go back to more analysis, so we want to do a good analysis before we do the conceptualization, but this is our chance. If we've missed something important, conceptualization gives us a chance to ask a few more questions, and then we can move into behavior change with confidence. So I want to just end by giving you guys a couple of resources. These are a couple of books. These are more books. The Real Behavior Change in Primary Care is a book that I wrote with Deb Gould, a physician friend of mine in Kirkstrassel a couple of years ago, and it talks about using acceptance and commitment therapy in primary care and provides a lot of case examples for using behavior change plans that are very amenable to team-based care. It also has some resources for primary care provider stress, how to assess it. There's a primary care provider stress checklist in there. And then there's a measure of psychological flexibility for primary care providers. There's some research and process in that area, and very exciting kinds of results in terms of implications for primary care behavioral health work. In This Moment is a book that is coming out very soon, and it's very brief kinds of skill building exercises that patients can learn, that providers of primary care can learn to transcend stress. And it explains the neuroscience behind these little brief but effective kinds of skills for really retraining your brain. The Diabetes Lifestyle book, available only as an ebook, is an evidence-based program using acceptance and commitment therapy. So encourage you to look at that. Again, more resources available online, and be sure to complete your learning assessment. So these are the questions, 3 core competencies for working briefly. You're naming one of your strengths and weaknesses on the ByCat. 1 strategy for adapting evidence for clinical interventions in the primary care context. So kind of adjusting towards the behavioral, looking at behavioral sorts of things. They work well in the brief interventions, adapting the evidence so that it really works with the patient's worldview, the patient's strengths and weaknesses. 1 type of PCBH service, remember we covered that, groups, brief interventions, classes, workshops, screenings, and then the pros and cons for assessing functioning versus symptoms in primary care behavioral health. And remember, I talked about what matters to patients. So these are some references that you might look at. On this page, the Robinson and Monday, that's the book chapter that I think Polly sent out that explains the ByCat more. I hope you'll use this tool to help you experience more success so that you stay in the field and get better and better. I think these are the main things. Thank you for your time and have a great day.
Wonderful. Thank you. Thank you so much, Dr. Robinson. For those of you still on the call, we did not send that book chapter out ahead of the call, but we will get that from Dr. Robinson and send it out immediately after the call. A couple of other things, as she said, please fill out the evaluation, which will be sent to you in email form after this webinar. And finally, remember next month on December 10th at noon Eastern Time, Dr. Jeffrey Ryder will have our next PCBH webinar, and I believe the topic for that webinar will be, let's see, it will be establishing, setting up a PCBH practice. And then we have our monthly PCBH SIG meeting the first Wednesday of each month. Our next meeting will be Wednesday, December 3rd at 3 p.m. Thank you all for joining us today, and have a great day.